Here we present our PMM2-CDG, small cohort of Brazilian patients with their clinical, biochemical, neuroradiological, and genetic findings. Phosphomannomutase deficiency, PMM2-CDG, is the most common type of CDG. Major clinical manifestations are found in children, including neurological involvement, cerebral hypertrophy or hypoplasia, hypotonia, strabismus, epilepsy, failure to strive, feeding difficulties, and developmental delay. Physical exam in those children show special findings like inverted nipples and abnormal fat distribution. Infections and fevers can also trigger stroke-like episodes, and thrombotic events can occur in patients undergoing surgeries without previous coagulation defects. Isoelectric focusing of serum transferrin is the standard test for diagnosis of CDG, especially in PMM2-CDG, due to any glycosylation involvement. And severe multisystemic disease can be responsible for poor prognosis on a subset of PMM2 patients. Those are involved with the glycosylation pathway, and it's the most common CDG in most of the population, with a frequency of 1 in every 20,000 births. So the objective of our work is to present a cohort of Brazilian PMM2 patients and their clinical manifestation. We have included 12 Brazilian patients, 10 males and 2 females. All have a confirmed PMM2 diagnosis by biochemical assay, enzyme assay, or genetic analysis. Clinical data, brain MRI, neurophysiological studies, hormone and biochemical tests, IAF results, and genetic testing were retrospectively reviewed. Our results showed that the mean age of diagnosis of our PMM2 patient was around 5 to 6 years of age, with a range from 6 months to 37 years. All patients had moderate to severe global neurodevelopmental delay. Only 2 patients were able to walk alone. The funny fact is that those only 2 patients were female patients. All non-ambulatory patients, but 1, had features of demyelinating peripheral neuropathy, as assessed by nerve conduction velocity. 2 patients in our series died in the first months of life after presenting with severe multisystemic disease in the neonatal period. Nevertheless, the remaining patients, but 1, neurological manifestations had an apparent static clinical course, dominated by mild to moderate intellectual disability and cerebral dysfunction, as you can see in this our patient. All our patients were compound heterozygous for PMM2 mutations, but 1, this one here, it was the only patient that was homozygous for a missense mutation. And he had typical facial features of CDG, including the brain MRI, that most of the patients had like a diversifying the cerebral hypoplasia or cerebral atrophy. The clinical phenotype PMM2 is very suggestive, but many pediatricians were not able to recognize most of those features. We have noticed that patients with prominent visceral or more systemic severe disease have early demise, and some of them were the ones with the early diagnosis, but it was not a rule. Since 2 of those patients had a very severe progression and in our cohort of patients, and they died even before reaching a clinical diagnosis. The cerebellum was nearly always affected in our cohort of patients, but fun fact is that most of those algorithms that involve cerebral ataxia, they do not include PMM2 as part of their algorithm diagnosis. We question if the PMM2-CDG can be underdiagnosed in patients with early onset presentation, since it was only 2 patients that had severe disease. It's not very common, or maybe those patients, they die before reaching a diagnosis. Most children in CDG without multisystemic involvement, as the other 10 patients, are able to reach adulthood, and many can be misdiagnosed with other disease, as we see like cerebral palsy. Better recognition and early management are essential in this disorder, not only for therapeutic reasons, but also for providing genetic counseling to the affected families. Thank you very much.